Good evening, students. Today we are going to discuss a very important topic, and moreover in this season you are going to see so many respiratory cases. So we will be discussing about COPD. We'll try to understand what exactly is COPD, how to approach to an exacerbation, and then we'll also be discussing all the recent guidelines 2021. So good evening, students. We will be discussing regarding COPD. Now first of all, what is the definition of COPD? I'll just write down the standard definition of COPD. Yes, students, good evening everybody. Are you there? So today we are starting with COPD, the standard definition of COPD. COPD is generally characterized by persistent symptoms. The symptoms can be similar to asthma symptoms. As we have discussed previously, patient can have cough, shortness of breath, chest tightness, wheezing, persistent symptoms, and airflow limitation. So the class has started. I want everybody to log in. It is characterized by persistent symptoms and persistent airflow limitation due to airway and alveolar abnormalities. Due to airway and alveolar abnormalities caused by significant exposure to noxious stimuli. Now this is the basic definition, students. Patient will have persistent symptoms. The word persistent is very important, and also persistent airflow limitation. Why it is happening? Due to airway and alveolar abnormalities, and why it is caused? Exposure to noxious stimuli. The noxious stimuli in the sense smoke generally. Then COPD historically is classified into two subtypes. The first subtype is emphysema and second is chronic bronchitis. Now emphysema is defined as destruction distal to terminal bronchiole. And this area distal to terminal bronchiole is called as acinus. Now if you take your lung, I think most of you know there is a large central airway called as trachea. Then trachea gives rise to principal bronchus. Then from the principal bronchus, on each side you have lobar bronchus, and from the lobar bronchus there will be segmental bronchus. Then from the segmental bronchus you will have tiny divisions, later on giving rise to terminal bronchiole. Generally, up to terminal bronchiole there will be no gas exchange. So this area is called as dead space. Now distal to terminal bronchiole there are tiny divisions called as respiratory bronchiole. Respiratory bronchiole. And respiratory bronchiole ultimately gives rise to the gas exchange units called as alveoli. Now this area, distal to terminal bronchiole, is called as acinus. Now in emphysema, this area, gas exchange area called as acinus, is getting destroyed. And depending on the part of the acinus, if central part is destroyed, it is called centriacinar emphysema. If distal part is destroyed, it is distal acinar emphysema. If the whole of acinus is destroyed, it is called as pan-acinar emphysema. So pathologically, depending upon the part of the acinus destroyed. Now if this central part, see the central part of acinus, the respiratory bronchiole that is destroyed, it is called as centriacinar emphysema. Centriacinar emphysema. So predominantly the central part of the acinus, respiratory bronchiole, can be destroyed. Now if at all the distal part of the acinus, distal part which contains alveolar duct and sac, alveoli, if these alveoli are predominantly destroyed, it is called as distal emphysema. Distal emphysema or distal acinar emphysema. If the whole is destroyed, if the whole acinus is destroyed, so this is called as pan-acinar emphysema. Pan-acinar emphysema. So generally it will be a mixture. It will not just be centriacinar, distal acinar, pan-acinar. Usually it will be a mixture. But if they ask you, where do you find commonly centriacinar emphysema? Smoking related emphysema is centriacinar. Whereas alpha-1 antitrypsin deficiency, alpha-1 antitrypsin deficiency causing emphysema is usually pan-acinar emphysema. So this is just for your clarification. The airway, it can be divided like this, from the trachea to tiny structure called as alveoli. In that, gas exchange unit is called as acinus. Acinus is area distal to terminal bronchiole. Now coming to chronic bronchitis. The chronic bronchitis, this is cough. Patient will have cough with expectoration. Cough with expectoration for more than 3 months. For more than 3 months in 2 consecutive years. In 2 consecutive years, and it can be associated with see this classification, cough with expectoration for more than 3 months in 2 consecutive years, associated with mucus gland enlargement, associated with mucus gland enlargement. And generally, for all practical purposes, now we don't label it as a single term, either emphysema or chronic bronchitis. Let it be any type, it should be labeled as COPD. So for practical purposes, it will be diagnosis of COPD, clinical features of COPD, treatment of COPD. And in majority, patients might have both elements, overlapping chronic bronchitis and emphysema. Patient can be having both elements in COPD. That's why we don't call it as emphysema or chronic bronchitis. We call it as COPD as a whole, because the current evidence demonstrates that most patients have both elements of chronic bronchitis and emphysema together. So that's why for clinical purposes, we don't call it as individual emphysema or chronic bronchitis. We have to call it with a single name called as COPD. We have to call it a single name called as COPD. I hope you have understood what is emphysema, what is chronic bronchitis, and what is COPD. For practical purposes, We don't call them as emphysema, chronic bronchitis. We just call it as COPD. Now let us see the burden of COPD. As of now, COPD is a cause of high mortality and morbidity. Is a high cause of mortality and morbidity. And in India, in 2019, so it is the second cause of death. Now if you see the causes of death, so the first is ischemic heart disease. Second is COPD. That's why COPD diagnosis and treatment is very, very important. And it is also the cause of disability. So third cause of disability. It is the third cause of disability in our country. It is the second most common cause of death in our country and third most common cause of disability in the country. It's like if you are studying about cardiac disease, which is resulting in death frequently, you should also study about COPD because it is the second most common cause of death. It is the second most common cause of death in our country. Let us see what are the COPD risk factors. I think most of you know, in majority, smoking is the most common risk factor. If you see 100 patients with COPD, 80% the risk factor will be smoking. Next is biomass fuel or solid fuel fires. And this is a very, very important cause of COPD in females. So this is a cause of COPD, especially in females of our country. Females of our country use biomass fuel for cooking. When the smoke is emitted from burning of biomass fuel, that when inhaled can also result in COPD. Then occupations such as coal miners. We have pollution. Pollution, both indoor and outdoor pollution. Then genetic deficiency, genetic disorder, alpha-1 antitrypsin deficiency. Let me tell you few important features of alpha-1 antitrypsin deficiency. It is a genetic disorder. It is chromosome 14 related. Because it is a genetic disorder, it runs in family. Somebody in the home will be having COPD. There will be family history of COPD. Less smoking history. Patient did not smoke at all or he just started smoking. There was development of COPD. Less smoking history but COPD. And importantly, young patient with COPD. Generally, for a patient to develop COPD, he should have smoked for 20 to 30 years. Now this fellow did not smoke at all and his age is only 15 or 20. He has developed fully blown out COPD. In that situation, one suspicion should be alpha-1 antitrypsin deficiency. Young age onset of COPD. Young age onset of COPD. Then next important factor that will be found in alpha-1 antitrypsin deficiency is there can be associated liver disease. Because of this problem, there will also be liver disease, and within the skin there can be necrotizing panniculitis. Necrotizing panniculitis, some inflammation within the subcutaneous tissue. And we can identify pathologically, radiologically, pan-acinar emphysema. There will be emphysema throughout. There will be involvement of the complete acinus. And there will be more of lower lobe predominant disease. Studies have shown whenever emphysema happens due to alpha-1 antitrypsin deficiency, it was observed. Exact reason is not known. It is based on observation. It was observed. The emphysema was predominantly concentrated in the lower lobes. So students, whenever you identify a COPD which is having family history, no smoking history, young patient, associated liver disease, it is a pan-acinar emphysema, lower lobe predominant disease, your suspicion should be a genetic cause called as alpha-1 antitrypsin deficiency. The next important factor is lung growth and development disorders. Whenever patient is having, so whenever patient has been born, this is a upcoming concept, patients born with low birth weight and in their childhood recurrent respiratory infections. So if they were born with low birth weight and recurrent respiratory infections, they can also develop COPD in adulthood. So this is a recent concept. Patients born with low birth weight and having recurrent respiratory infections in the childhood can later develop COPD. So if you notice the causes here, most important is smoking. Next we have biomass fuel exposure, occupational exposure, pollution, genetic causes, and the recent concept low birth weight and recurrent respiratory infections in childhood. Recurrent respiratory infections in childhood, all this can contribute for development of COPD. But in my clinical practice, most commonly what I come across is smoking. So these are the COPD risk factors. If somebody asks you in your Viva examination what are the causes of COPD, just don't say smoking. Along with that, biomass fuel exposure, occupational exposures, pollution, alpha-1 antitrypsin deficiency, low birth weight and recurrent respiratory infections in childhood can also predispose for COPD development. Then coming to the pathophysiology and clinical features. First we will discuss the general pathophysiology, then we will see in detail what can happen in emphysema, what can happen in chronic bronchitis. Even though it is a very complex mechanism, I will try to simplify for you to understand and easily represent in your exam. Now see here students, these patients will have airflow limitation. There will be no proper flowing of air. There can be air trapping, gas exchange abnormalities. There will be gas exchange abnormalities. And moreover, because of mucus hypersecretion, you can notice the airway getting closed with secretions like this. The main important features in COPD, why patient is having symptoms, will be airflow limitation, air trapping, gas exchange abnormality, and a mucus hypersecretion. These are the four important features you have to address. Now let us see why there is airflow limitation, why there is air trapping, why there is gas exchange abnormality, and why there can be mucus hypersecretion. These are the important problems that will be happening in the lungs of COPD. There will be narrowing of airways and air will not come out, resulting in air trapping. And because of damage to alveolar walls, capillary walls, there can be gas exchange abnormalities. And due to over secretion of mucus by the goblet cells, airways can be filled with mucus. Now why all this happens, the precise molecular mechanisms, let us see. Let us start with why there is airflow limitation and air trapping. Why there is airflow limitation and air trapping. Now we know that the risk factors, there can be smoking, air pollution, or genetic predisposition such as alpha-1 antitrypsin deficiency. So here, what can these factors do? What can smoking do? What can pollution do? And these genetic factors put together. Generally in a patient, there will be combination of these risk factors. Because of smoking, air pollution, there will be oxidative stress. So the smoke can trigger free radical release, resulting in oxidative stress, and there will be increased free radicals, reactive oxygen species. And whenever a patient is actively smoking, smoking can trigger inflammatory phenomena in the lung. There will be accumulation of inflammatory cells. Whenever there is long-standing smoking, it can stimulate inflammatory cells within the lung, accumulation of inflammatory cells. And these cells are very important. Now when you see in asthma, it is more of eosinophils. Here neutrophils. In asthma, it will be more of Th2 response, helper cells, CD4 Th2 response. But here, what are the cells participating in the inflammation? CD8 T lymphocytes. So these are CD8 T lymphocytes, and important cytokines responsible here will be interleukin 8, TNF alpha. In asthma we have discussed important were IL4, IL5, IL13. Whereas in COPD, important cells, whenever patient is actively smoking, so it can activate an inflammatory response within the lungs. Which cells are important? Neutrophils are important. CD8 T cells are important. And there will also be release of mediators such as interleukin 8, TNF alpha. Then these patients, they can also have elastase, anti-elastase imbalance. So what happens is, suddenly due to smoking, air pollution or genetic predisposition, normally elastases and anti-elastases will be in balance, so that there will be no excess destruction of elastic tissue in the lung. Now because of this risk factor, suddenly the anti-elastases can decrease. This smoking and air pollution, so these particles can stimulate elastase release in the lung. So whenever elastases increases, there will be damage to elastic tissue resulting in hyperinflation that we will see. These are the three things that can happen. So first is there will be increased oxidative stress, ongoing inflammation and increased elastases. Now because of these three mechanisms, what can happen? There will be alveolar wall destruction. There will be alveolar wall destruction. And these three mechanisms will be responsible for the airflow limitation, air trapping and also gas exchange abnormalities. Out of this, most famous is this mechanism, elastase, anti-elastase mechanism. Now let us see how will this elastase, anti-elastase imbalance result in airflow limitation, air trapping and alveolar wall destruction. So this can result ultimately in emphysema. Let us see the emphysema predominant pathophysiology. So this is the general pathophysiology. So smoking, air pollution, genetic predisposition can result in oxidative stress, accumulation of inflammatory cells, elastase, anti-elastase imbalance and ultimately alveolar wall destruction. Now out of this, important will be elastase, anti-elastase imbalance. And because of this elastase and anti-elastase imbalance, there can be changes called as emphysema happening. So now let us see how will these emphysematous changes happen because of this elastase, anti-elastase imbalance. Normally at expiration, see here students, normally at expiration your alveoli tend to be partially open. So alveoli tend to be partially open. So now whatever I am writing here, I am discussing the normal phenomena. Normally at expiration your alveoli tend to be partially open. Now what is the reason for alveoli to be partially open? Because within the alveoli there is a substance called as surfactant. Now interesting feature here is airways that are connecting into the alveoli, they will also be partially open. The reason is around the airways there can be plenty of elastic fibers. Around the airways there can be plenty of elastic fibers. Now these elastic fibers these elastic fibers apply outward traction. These elastic fibers can apply outward traction to keep airway open. Now interesting aspect here is, at expiration in a normal individual, your alveoli are partially open and the airways connected to the alveoli are also partially open. Let us see what happens in a patient with emphysema. Say this fellow is developing emphysema. As I told you, most common phenomena is smoking. And we have a genetic defect called as alpha-1 antitrypsin deficiency. Let it be any of this feature. Smoking can increase elastase. Alpha-1 antitrypsin deficiency can also increase elastases in the lung. Now wherever elastases are there, what is its function? Damage to elastic fibers. Now these elastases will start damaging the elastic fibers. As you know, smoking not only increases elastases, and whenever there is some ongoing inflammation, apart from the elastases, there can be accumulation of so many inflammatory cells. Already we have discussed the inflammatory cells. There can be neutrophils, there can be lymphocytes, CD8 T cells, inflammatory cells. Now first let us see what happens due to increased elastase. Now we know that these elastases are required to keep the airway patent during expiration. Now for example, let this alveoli contain 100 units of air which has to be expelled during expiration. So whenever this 100 units has to be expelled, even the airways connected to the alveoli should be opened during expiration. Now what is happening in emphysema? There is destruction of elastic fibers. So this airways close early. So when this airways close early, instead of 100 going out, only 50 will go out. If airways were open, all the 100 units of air was going out. Now airways are getting closed early. So instead of 100 going out, only 50 will go out, resulting in air trapping. So this is the phenomena that can happen because of damage to elastic fibers. Because of damage to elastic fibers, there will be early closure of airways during expiration, and this results in air trapping in alveoli. Now if years progress like this, this phenomena will continue. Because of that, what will happen? Now as time progress, what are the changes that can happen? Now this airway narrowing, it will become more and more narrowed. Your airway will become more and more narrowed. Now with each expiration, instead of 100 going out, only 50 is going out. Now what happens is, as years progress, all your alveoli will become over distended. These over distended air sacs, they are also called as bullas. Now why all this has happened, students? Because of damage to elastic fibers. Now this alveoli is filled with excess air, so there can be increased residual volume. Whenever residual volume increases, automatically in the lung function test, FRC and total lung capacity will increase. Now if you notice, this was the initial radius of the airway. Now this is the radius of the airway. There is decrease in airway radius. Whenever airway radius decreases, what can automatically increase, students? airway resistance can increase. Whenever airway radius decreases, airway resistance can increase. And moreover, this inflammatory cells have also accumulated. Now what will these do? These inflammatory cells can cause involvement of alveolar and capillary walls. They can cause destruction of alveolar and capillary walls. Simultaneously, there will be destruction of alveolar and capillary walls. Normally, your alveolar and capillary walls should be very smooth like this for gases to diffuse. Whenever they are getting damaged, now they become rough, and rough alveolar capillary membrane cannot facilitate proper diffusion of gases. This results in decreased diffusion of gases. These are the important points that you should know regarding pathophysiology of emphysema. There will be air trapping, decreased airway radius, increased airway resistance, increased lung volumes, formation of bullas, decreased diffusion of gases. These are the important pathophysiological features of emphysema. Now see here, because the lung volume is increasing, now the lung will not only expand sidewards, it can also expand antero-posteriorly. Whenever lung is expanding antero-posteriorly, there will be increased AP diameter. Now this increased AP diameter, it is called as barrel-shaped chest. Increased AP diameter is called as barrel-shaped chest. Now this will be the X-ray features in a patient with emphysema. Now see the first X-ray. This is a normal chest X-ray. You can see the normal lungs. This is the size of the normal lung. So these are the diaphragms, curved diaphragms, and your heart is having a globular shape. Now in emphysema, what will happen is the lungs become very, very big. Whenever lungs become very, very big, they can push the diaphragm down. That results in flat and low-lying diaphragm. So first important is bilateral hyperinflated lung fills. Bilateral hyperinflated lung fills. Now these lungs have become very big. Because of that, it can apply weight on diaphragm. Because of that, curved diaphragm can become flat and low-lying. Can you see the second image? There is flat diaphragm. And previously, in this compact space of a normal individual, your heart was packed like a globe. Now whenever your lungs pushes the diaphragm down, now this globe will adjust like a tube. This phenomena is called as tubular heart. Now you can notice, heart is looking like a tube. This is tubular heart. All these features are happening due to air trapping. Because of air trapping, the lung size increases. It will apply weight on the diaphragm. Because of that, curved diaphragm can become flat, low-lying. And in that space, your globular heart can adjust like a tubular heart. Three important signs: bilateral hyperinflated lung fills, flat diaphragms, your globular heart appearing like a tube. Then let us see the clinical features. If you notice here, what is this? This is anterior portion. This is posterior portion. There is increased AP diameter. And this increased AP diameter is called as barrel-shaped chest. Now this is a patient with fully blown out emphysema. This is how he looks clinically. You can see here, students. So this patient will be very lean, and he will be taking a characteristic breathing. So what is this breathing called as? So it is called as pursed lip breathing. It is called as pursed lip breathing. Now let us see the important mechanisms in emphysema. Emphysema historically was called as pink puffers. So these people were called as pink puffers. No longer we are using the terms pink puffers and blue blotters for clinical purpose. We call it as COPD, but few old examiners might be there who will be stressing why emphysema patients are called as pink puffers, why chronic bronchitis patients are called as blue blotters. So let us see this. These patients have dyspnea as chief complaints because they are having destruction of alveolar walls, and these patients gas exchange may be affected, so they might be taking ventilation more and more. They will be thin non-cyanotic because always they are consuming their energy for respiration. These patients will be thin and they will be non-cyanotic. Because they are not cyanotic, they will not be blue, they can be pink. Because they are not cyanotic, they will not be blue, they can be pink. And there is no peripheral edema. And these patients, even during the rest, they will be uncomfortable with accessory muscle use. You can see this patient. He was at rest, he is uncomfortable, he is using his neck muscles for respiration. And if you put your stet, there can be mild wheezing, not noisy chest, quiet chest or mild wheezing. And on the chest X-ray, one can notice hyperinflation and diminished vascular markings. Now because the lungs have expanded, the vessels may not appear properly, so there can be diminished vascular markings. Now what was the reason for this patient to be pink? Why he is not becoming cyanotic? So this is an historical explanation again. See, the exact mechanism is not yet known. This is the probable mechanism of this patient not developing cyanosis. Now what happens is, in a normal individual students, if you consider alveoli is this and blood vessel is this, the ventilation and perfusion will be matching. If there is 1 unit of ventilation in the alveoli, God has adjusted perfusion in the blood vessel as also 1 unit. So always ventilation and perfusion will be matching together so that good gaseous exchange is happening. Now what they have understood in emphysema is, in emphysema there is ventilation perfusion mismatch. Now there is alveolar capillary damage, and they have noticed that there was significant capillary injury. Because of that, this perfusion has decreased to 0.25 units. Ventilation is also decreased, but it is 0.75 units. So it means relatively in these patients, ventilation is preserved. So their capacity to ventilate has been preserved. See, on the whole, ventilation has decreased, but when compared to perfusion, ventilation is still maintained. So these patients have preserved ventilation. They can have preserved ventilation when compared to perfusion. Preserved ventilation when compared to perfusion. Now because there is preserved ventilation, see, there is damage in perfusion, but still ventilation is there. So to facilitate gaseous exchange, these patients will hyperventilate. It is just like See here, students, if there is a cricket team, both batsmen and bowlers should be performing well, just like Australia team. Both batsmen and bowlers should be performing well for the team to win. Now if it is Afghanistan team, rather than batsmen, bowlers will perform more. So whenever the batsmen are not all working, now bowlers will overwork so that they will make their team win. Now here also what is happening in COPD emphysema is ventilation is just like their bowlers. It is still healthy, but perfusion is damaged. Now to maintain gaseous exchange, what your body will do is there will be more and more ventilation. So to preserve the gaseous exchange, see, perfusion is not working. Normally both should be working for gas exchange to happen. Now here what is happening? Perfusion is not working properly. So what will your body do? Your body will hyperventilate. It's like if batsmen have failed, now bowlers have to overwork to make sure the team is winning. In the same way, here the batsmen have failed, the perfusion has failed. Now it is up to ventilation to maintain gaseous exchange. There will be hyperventilation to maintain gaseous exchange. Always patient will be taking more and more ventilation, because he is always taking more and more respiration. This fellow will be uncomfortable with accessory muscle use, and because he is putting all his energy into ventilation, this fellow will be thin. Now because of ventilation, the oxygen is entering into the body, and this fellow will be non-cyanotic. Non-cyanotic in the sense he can be pink. Now this fellow is having expiratory airflow limitation. Now during expiration, air is not going out. Normally during expiration, air should go properly. Now because it is not going out, because there is difficulty in expiration, now what these patients do is, to facilitate expiratory air outflow, he makes a breathing called as pursed lip breathing. So what he does is, he creates a positive pressure within his lungs during expiration by puffing. So he will puff his cheeks. By puffing his cheeks, he will be able to create positive pressure within the lung. So that positive pressure will facilitate air to exit through the airways. See, normally what is happening during expiration, these are closing. So what will these patients do? Now see here, once he puffs, when he does like this airways will open, and from this airway he is slowly expelling the air out. So this is called as pursed lip breathing, because he is puffing his cheeks. He is called as pink puffer. He is puffing his cheeks. He is called as pink puffer. So there will be pursed lip breathing to facilitate air exit during expiration. Pursed lip breathing. So pursed lip breathing for better exit of trapped air. It is simple mechanism. During expiration, his airways are closed like this. Now what this fellow do? He will make a puff. So this puff can create a positive pressure, and it can facilitate the airway to open. Now because airway has opened, now this air has to be sent out by the patient voluntarily. So what he does, he will send this air like this. So in this way, he will be able to send the trapped air out. Now in this patient, what is happening? Still there is preserved ventilation. So to maintain gaseous exchange, your body will hyperventilate, because oxygen is able to come into the circulation. Patient will not be cyanotic, so he will be pink. and to facilitate the exit of trapped air, patient will be having the classical pursed lip breathing. And because he is pursing his lips and he is also making a puff with his cheeks, he is called as pink puffer. So this is the classical presentation and explanation of emphysema. Now coming to mechanism of mucus secretion, and this mechanism of mucus secretion is a classical feature of patients with chronic bronchitis. It is a classical feature of patients with chronic bronchitis. Because of smoking, there can be bronchial irritation and inflammation. Whenever patient is smoking continuously, this smoke can irritate the bronchus. And it can cause inflammation. And remember students, a COPD patient will be having both aspects. He will be having emphysema and chronic bronchitis. It will be overlapping. So don't think there will be an isolated emphysema, isolated chronic bronchitis. So generally both will be overlapping in majority. In few, one may be predominant when compared to other. So that is a rare entity. Usual patients will be having both together. Bronchial irritation and inflammation that can result in mucosal gland hypertrophy and hypersecretion. Because of smoking, there will be bronchial irritation and inflammation, and that can result in mucosal gland and hypertrophy. So once the mucus glands are becoming big and they are secreting excess mucus, that will result in more and more of mucus secretion. And due to the long-standing inflammation, there can be narrowing of small bronchi and bronchioles, resulting in airflow obstruction. So this will result in mucus secretion. The mucosal gland hypertrophy and hypersecretion will be resulting in more and more mucus secretion. So it will result in more and more mucus secretion. And due to long-standing inflammation, there can be narrowing of bronchi and bronchiole. And because of narrowed bronchi and bronchioles, there is airway obstruction. Now if you notice here, in this mucus hypersecretion chronic bronchitis phenomena, more of airway involvement rather than the capillary involvement. So there is mucus gland hypertrophy, hypersecretion, mucus hypersecretion, then long-standing inflammation can result in narrowing of small bronchi and bronchiole, ultimately resulting in airway obstruction. Long-standing inflammation can result in narrowing of small bronchi and bronchioles, resulting in airway obstruction. Now this will be a X-ray of a patient with chronic bronchitis. There can be some cardiomegaly. Now why there is cardiomegaly, I will tell you in the second slide, next slide. And due to mucus, there can be increased bronchial markings. Now on the wall of the bronchi, there will be mucus and it can appear as increased bronchial markings. Now why there is cardiomegaly, I will tell you in the next slide. And there can be increased bronchial markings due to mucus lining the bronchus, Now this is how a patient with chronic bronchitis appear. He will be comfortable at rest, he will be obese, and he will generally be cyanotic. So this saturation at rest, it will be very less. He will be having hypoxemia, resting hypoxemia, and you can see his lips, actually they are very blue because he is a dark colored person, you are unable to appreciate. Now see this patient, he is a chronic bronchitis predominant. And because of secretions, there will be cough as chief complaint. And these patients are obese, cyanotic, and edema is seen. Now why there is obese, cyanosis and edema here? Again the simple mechanism. Now when you see a chronic bronchitis predominant patient, now let this be his alveoli and let this be the circulation, capillary. Now whatever changes is happening in chronic bronchitis, it is more in the airway. See, there is mucus accumulating in the airway, inflammation. Because of this, there will be more decrease in ventilation. So here ventilation is weak, more decrease in ventilation when compared to perfusion. Now to facilitate the gaseous exchange, what will your body do? Because ventilation is damaged. When batsmen are damaged, bowlers overdo. So in the same way, when bowlers have not performed well in the first innings, next innings batsmen have to overdo. Now because here ventilation is affected, now your body tries to maintain gaseous exchange by more and more perfusion. Now whenever the perfusion tries to increase, now what is going to happen? Now blood is flowing here, but this blood is not getting sufficient oxygen because ventilation is predominantly damaged. There will be hypoxemia. Now because of hypoxemia, early hypoxemia, this patient will develop very early hypoxemia that will result in cyanosis. Whereas there ventilation was preserved, so still oxygen was going into that blood vessels. So patient was not becoming blue. Here the perfusion can increase, but to that blood oxygen is not mixing. Whenever oxygen does not mix blood will become blue, blood will become more deoxygenated. That phenomena is called as cyanosis. Now because of this early hypoxemia, there can be early hypoxemia, and persistent hypoxemia can cause persistent pulmonary vasoconstriction. You must be knowing in your pulmonary circulation there is a special feature. What is that special feature? Pulmonary circulation has hypoxia sensitive potassium channels. Whenever there is less oxygen, these potassium channels will react, resulting in pulmonary vasoconstriction. Now because of pulmonary vasoconstriction, there will be predominant pulmonary hypertension, and this pulmonary hypertension can result in right ventricular dysfunction, and this right ventricular dysfunction is nothing but cor pulmonale. And whenever there is right heart failure, there can be fluid retention and it can cause edema, and that might be the reason why patient is obese and why there is edema. And moreover, his ventilation is also not increasing. Persistent pulmonary vasoconstriction, pulmonary hypertension, right ventricular dysfunction, and this can result in patient to appear obese. See, don't think that in emphysema cor pulmonale will not happen. So it will happen at late stages. Whereas in chronic bronchitis, this will happen in early stages. Even in emphysema, ultimately when patient's respiratory effort is not sufficient to maintain oxygenation, they also can develop pulmonary hypertension cor pulmonale, but it is at a later stage. Here patient develops early cor pulmonale and early pulmonary hypertension. And this patient looks comfortable at rest. Because his body is trying to maintain gaseous exchange by perfusion. There can be no significant rise in ventilation. He will be comfortable at rest. Because of some unknown reason, his ventilatory drive may also decrease gradually, so he will be bit comfortable at rest. And if you put ears there, because of secretions, there can be noisy chest with rhonchi. And on the X-ray, you can see the bronchial markings has increased. And this patient progresses fast to cor pulmonale and respiratory failure. Now because there is less ventilation when compared to perfusion, less oxygen is going into the blood. So blood will turn blue early, blood will become hypoxemic. Because of hypoxemia, there will be persistent pulmonary vasoconstriction, pulmonary hypertension, right ventricular dysfunction, edema. And these are chronic bronchitis predominant. I hope you have understood now why they are called as blue bloaters, because they develop early cyanosis. They are blue and they have become edematous. They have bloated. So they are called as blue bloater. These are the two features. They develop early cyanosis and they become edematous due to right ventricular dysfunction pulmonale. So they were called as blue bloaters. See, once again you see here, this patient is bloated and he is having cyanosis and he is comfortable at rest. When you see his saturation, even at rest, it was very less. See his saturation. So it is 84%. It is 84% less. Generally, chronic bronchitis patients will look like that. Now coming to what are the gas exchange abnormalities overall in COPD. And once again, my advice to you is, ultimately don't try to search for emphysema and chronic bronchitis component in the patient. Let it be anything, label him as COPD. Now what can be the gas exchange abnormalities? Whenever alveolar cells are damaged, or alveolar walls are damaged, oxygen cannot penetrate into circulation. Because oxygen cannot penetrate into circulation, patient will develop hypoxemia. Then I told you in emphysema predominant, there is airway narrowing, there is early closure of airways during expiration. Then CO2 cannot go out. Whenever CO2 cannot go out, there can be hypercapnia. And these patients can also have some amount of diaphragmatic impairment. This diaphragmatic impairment is actually a feature of lung hyperinflation. Whenever your lungs are hyperinflated, it applies weight on diaphragm. Your diaphragm is also a muscle and it is one of the strongest respiratory muscle. Because of excess weight on the diaphragm, your diaphragm cannot move properly. Once diaphragm is not moving properly, there will be decrease in respiratory effort. Once there is decrease in respiratory effort, insufficient inspiration. The amount of oxygen coming into your lungs will be less. Insufficient expiration. The amount of carbon dioxide going out from your lungs will be less. Because oxygen is not coming into the body, patient will have hypoxemia. Because the carbon dioxide is not going out from your body, patient will have hypercapnia. But in a real life scenario, to exactly know the oxygen level and the carbon dioxide level, you need ABG. But if ABG is not available, you can at least see the SpO2 and you can assess the patient. Now this will be a classical presentation of COPD. There might be a patient with SpO2 75% in emergency department. Now whenever you see a patient with 75% in emergency department, usually if it is a routine respiratory disease, what you do, you give excess oxygen and you try to bring the saturation to normal value, 94 to 96. Now can this practice be done in COPD? Can you give excess oxygen to a patient with COPD and bring saturation to normal value? Yes or no, students? I want you to answer. If there is a known COPD patient with low saturation, will you give him high flow oxygen and bring his saturation to normal? Can this be practiced, yes or no? The answer is no. In COPD, you should never give excess oxygen and you should never try to normalize his SpO2. Now what is the reason behind this? COPD is a separate disease when compared to other respiratory disorders because it takes at least 20 to 30 years to develop COPD and patient will live with COPD another 10 to 15 years. Because of this long duration of the disease, there can be some permanent changes happening in the respiratory receptors. You must be knowing respiratory receptors are of two types. Central chemoreceptors, taking care of carbon dioxide, hypercapnic respiratory drive. Whereas peripheral chemoreceptors taking care of oxygen, hypoxemic respiratory drive. What happens in COPD is this patient is having continuous hypercapnia and continuous hypoxemia. Continuous hypercapnia and continuous hypoxemia. Now because of continuous stimulation of your central chemoreceptors, after few years your central chemoreceptors will become tired and they will give retirement. See here students, whenever there is a switch like this, if you keep on pressing the switch for years together, if you keep on pressing the switch for years together, what will happen? The switch will stop functioning. So in COPD patients also, as years progress, the central chemoreceptors will become tired and they announce their retirement. Now the whole burden of breathing is taken care by your peripheral chemoreceptors. Now your peripheral chemoreceptors are also continuously stimulated. But point to know here is your peripheral chemoreceptors are very loyal to your body and they are very durable. They will not give up. They will fight up to the last breath. It is just like humans' tendency. Whenever you allot a work to them, few people will leave the work early and they give up. But few people will work up to their last breath. It is just like Amitabh Bachchan and Abhishek Bachchan. Amitabh Bachchan is a peripheral chemoreceptor. So he is still acting. Whereas Abhishek Bachchan becomes tired, he has stopped acting for our good. Now if you give excess oxygen to the patient and normalize the SpO2. Now why this patient is breathing? Because of hypoxemic respiratory drive. Now if you normalize his SpO2, that hypoxemic respiratory drive will be abolished. Already central chemoreceptors not working. Now peripheral chemoreceptors have no stimulus. So the patient's breathing will stop and there will be stoppage of respiration. Write down this mechanism from new edition of Guyton. See here what happens is in chronic hypercapnia. As years progress, your central chemoreceptors will become tired and they will announce retirement. CO2 level may not stimulate respiration properly. And these patients will be breathing only because of hypoxic drive. Your peripheral chemoreceptors are very loyal to the body. They will be fighting till the last breath. Now if you give excess oxygen and hypoxic drive is withdrawn by excess oxygen, breathing may stop. Now if you give excess oxygen, why the patient is breathing? Because of hypoxia. That hypoxia might be withdrawn and patient might stop breathing. Then what is the solution? If you don't give oxygen, patient's vital organs such as the brain, kidney, liver, heart cannot function. So the concept here is instead of giving high flow oxygen, we can give low flow oxygen. So for this patients, low flow oxygen can be given and target SpO2. Target SpO2 should be maintained 88 to 92%. No need to normalize the SpO2. Always try to maintain some degree of hypoxemia. Instead of targeting SpO2 to 94 to 96, you just bring it to 88 to 92%. So with this oxygen, your body organs can function. Still there will be some amount of hypoxemia which will be stimulating the peripheral chemoreceptor and respiration will be happening. Now this respiratory drive concept is traditional teaching. So up to now what we have known in COPD, why there is stoppage of breathing when you give excess oxygen, this was the reason. Because in chronic hypercapnia, your central chemoreceptors are not functioning. Whole burden of respiration is taken care by your peripheral chemoreceptors. And the stimulus of peripheral chemoreceptors is hypoxemia. If you give excess oxygen, that stimulus is withdrawn and the breathing might stop. Now the new concept, recent concept is why I should not give excess oxygen. So what happens is there is a phenomena called as Haldane effect. If excess oxygen given, if excess O2 given, what happens is CO2 can be released from hemoglobin. See, normally what happens, if patient is given, if he takes oxygen, CO2 will be released from the hemoglobin, and the opposite of this is called as Bohr effect. So this effect is called as Haldane effect. Now already patient is having hypercapnia. Now if excess CO2 is released from hemoglobin, there can be worsening of hypercapnia. Worsening of hypercapnia. So whenever you give excess oxygen, so this oxygen will release CO2 from the hemoglobin. Already patient's body is having excess carbon dioxide. Now if you give excess oxygen to them, this CO2 will be released from hemoglobin and there will be worsening of hypercapnia. Whenever CO2 increases, there can be CO2 narcosis. At very high value, CO2 can act like a narcotic, resulting in respiratory depression. And another concept is, this is very recent, giving excess oxygen can worsen ventilation perfusion mismatch. So this was an observation. Exact mechanism is not known. Recent studies have shown that giving excess oxygen can worsen ventilation perfusion mismatch. So the precise mechanisms are unclear, but this is also considered as recent concept. So let it be the old hypoxemic respiratory drive theory or the new concept Haldane effect or ventilation perfusion mismatch. All this says only one thing: don't give excess oxygen to a patient with COPD. Don't be a hero by giving excess oxygen, because patient's respiratory effort can become zero. This is one thing I tell all my first year PGs and also interns. Whenever they see midnight a patient with COPD giving excess oxygen, bringing his SpO2 to 96, 98 is counterproductive. So the traditional teaching says that if you give excess oxygen, there can be abolition of hypoxemic respiratory drive. The recent concept says that in your body generally there is something called as Haldane effect. If somebody takes excess oxygen, there will be carbon dioxide released from the hemoglobin to attach to that oxygen. So already a patient with COPD will be having lot of carbon dioxide in his body. Now giving excess oxygen results in release of carbon dioxide from the hemoglobin. So this can increase the hypercapnia. Whenever there is a significant hypercapnia, patients can develop CO2 narcosis, respiratory depression. And another concept is giving excess oxygen might worsen ventilation perfusion mismatch. So this mechanism is slightly unclear. So if an examiner asks you why I should not give excess oxygen, you should tell these three. Traditional theory, abolition of respiratory drive by excess oxygen. New theory, Haldane effect, and oxygen can worsen ventilation perfusion mismatch. The next important feature in COPD is, so we have started with these three factors. This was a thing I started with. The airflow limitation, gas exchange abnormality, mucus hypersecretion, and we have seen what are the mechanisms of airflow limitation and air trapping. What is emphysema predominant and what is chronic bronchitis predominant. Now common to these, there can also be ultimately pulmonary hypertension, respiratory failure and exacerbation. Pulmonary hypertension is predominantly due to long-standing hypoxemia. The mechanism can cause persistent pulmonary vasoconstriction. It can cause persistent pulmonary vasoconstriction. Because of persistent pulmonary vasoconstriction, that can result in pulmonary hypertension. and these patients can have respiratory failure due to defective gaseous exchange. There will be defective gaseous exchange that can result in respiratory failure and worsening of pre-existing COPD. Worsening of pre-existing COPD. It is called as exacerbation. And this exacerbation can happen due to a new infection, or it can happen due to the disease process itself worsening. Disease process, the inflammatory damage might increase. The smoking related inflammation can increase. Respiratory failure, it is due to defective gaseous exchange, and exacerbations, it can be due to worsening of pre-existing COPD. Worsening of pre-existing COPD. Then coming to systemic features. A COPD patient, because of inflammation related to smoke, can have some systemic features. That's why nowadays COPD is also called as a systemic inflammatory syndrome. COPD, in some books it is also written as systemic inflammatory syndrome. Let us see what are the important features. Now you know that in COPD there is a lung inflammation happening. Now as a part of lung inflammation, so many inflammatory mediators, as we discussed, interleukin 8, there can be release of TNF alpha, there can be stimulation of CD8 T cells. These inflammatory mediators, they can spill into circulation. Once they go into circulation, so the inflammatory mediators such as neutrophils can release IL-6, COPD inflammation can result in TNF alpha, interleukin 1 beta. These are the three important substances: IL-6, interleukin 1 beta, TNF alpha. So these will go into the circulation and they can trigger few events. So what is the first important event? It can cause osteoporosis. Now what is the reason for osteoporosis? This TNF alpha, interleukin 1 beta and IL-6 can cause stimulation of osteoclastic activity. It can stimulate osteoclastic activity. Once the osteoclasts are stimulated, there will be bone resorption. Can COPD be responsible for weak bones? Yes. What is the mechanism? There can be spillover of inflammation from the lung into circulation. And what are the substances that are related? IL-6, IL-1 beta, TNF alpha. It can stimulate the osteoclast, resulting in bone resorption. So this is the number one feature, that is osteoporosis. Coming to the number two, there can be muscle wasting. The patient can become very lean and muscles can get wasted. Now what is the reason? What is the reason for muscle wasting? What is the reason for muscle wasting? The reason is because of systemic inflammation, and there can also be release of nuclear factor kappa B. This will result in excess oxidative stress. Excess oxidative stress, and that can result in muscle dysfunction, atrophy, weight loss. Whenever there is excess oxidative stress in your body, your muscles may not function properly. There can be muscle dysfunction, atrophy and weight loss. The result is due to systemic inflammation, activation of nuclear factor kappa B in the muscle, and also ongoing oxidative stress. These three are contributory factors: systemic inflammation, activation of nuclear factor kappa B in the muscle, and increased oxidative stress. This can cause muscle dysfunction, atrophy, weight loss. And third important is development of coronary artery disease, cardiac events. So the reason is because of continuing systemic inflammation, there can be formation of atherosclerotic plaques. And this atherosclerotic plaques will result in coronary artery disease. And this is the reason why so many patients with COPD will also be having coronary artery disease. This inflammatory mediators can result in inflammation in coronary arteries, resulting in formation of atherosclerotic plaques. Then these patients, interestingly, can also develop poor control of diabetes, insulin resistance, because of TNF alpha and IL-6. They can block the signaling through the insulin receptor, resulting in insulin resistance. They can block signaling, they can act on the insulin receptor, and it can result in insulin resistance, resulting in type 2 diabetes. Or these patients with pre-existing diabetes will have poor glycemic control. And what are the mediators responsible? TNF alpha, IL-6. It can result in, it can alter the insulin receptors, and it can result in insulin resistance. Then ultimately, because of these inflammatory mediators, these patients can have some psychosocial features. They can also develop depression. These patients, because of chronic symptoms and ongoing inflammation, they can also develop depression. If they ask you, what are the systemic manifestations of COPD? Patient can develop osteoporosis due to increased osteoclastic activity. Patient can develop muscle wasting because of ongoing inflammation, oxidation, stress, nuclear factor kappa B activation, resulting in muscle dysfunction, atrophy, weight loss. Due to chronic inflammation, atherosclerotic plaque formation, resulting in coronary artery disease. Inflammatory mediators can modify the insulin receptors, resulting in insulin resistance, type 2 diabetes. These inflammatory mediators, put along with patient symptoms, can result in depression. So the systemic features are osteoporosis, muscle wasting, coronary artery disease, insulin resistance, depression. These are the important pathophysiological mechanisms of COPD. So we have understood the reason for air trapping, airflow limitation, gas exchange abnormalities, then why there can be mucus hypersecretion and pulmonary hypertension, why there is respiratory failure, and these patients can develop worsening called as exacerbations. Then coming to presentation, how will a patient with COPD present to you? Usually he will be elderly. Patient reaches you in the 5th decade, because for a patient to develop COPD, he should have smoked at least 20 to 30 years. By the time he starts smoking, his age generally will be 20 years. If he continues to smoke, he will manifest at his 50th to 60th year. Then these patients will have significant shortness of breath. Next important symptom they tell you is they are having shortness of breath, and also cough. There can be cough with sputum. Cough with sputum. And patients with COPD will also tell you headache. Can anybody tell me why there is headache? Because of hypercapnia. CO2 retention can result in cerebral vasodilatation and headache. Headache due to hypercapnia. Patients can have headache due to hypercapnia. They can have edema. Why edema? As a part of right ventricular dysfunction. They can have edema as a part of right ventricular dysfunction. And systemic features. Patient can be having weak bones, muscle pains, all the muscle pain, weakness, fatigue, all the systemic symptoms. Patient can have systemic symptoms such as muscle weakness and fatigue. This will be the usual presentation of a patient with COPD. He will be elderly, smoker, can present with breathlessness, cough with expectoration, headache due to hypercapnia, peripheral edema, systemic symptoms such as muscle weakness, fatigue. Systemic symptoms such as muscle weakness, fatigue. This is the usual presentation of a patient with COPD. Usual presentation of a patient with COPD. Then how to differentiate asthma and COPD? Generally asthma, it will be allergen related. COPD is usually smoking related. Asthma will have reversible airflow limitation. COPD can have persistent airflow limitation. Asthmatics majority will be young, early presentation. COPD, elderly. Asthma, as we have discussed yesterday, it is reversible airflow limitation. So patients will have good relief with bronchodilators. COPD, it is only partial response. Asthma, Usually patients will have normal chest X-ray, whereas COPD, there can be bilateral hyperinflated lungs. So in short, asthma is something happening very early in your life, mostly reversible, just like one's girlfriend. Whereas COPD happens late in your life and mostly persistent, just like one's wife. So in short, the difference between asthma and COPD. Nowadays, we are also seeing a new entity called as asthma COPD overlap, where patients can have coexisting features of both asthma and COPD. But generally, this is how we can differentiate an asthmatic and COPD. Asthma, spirometry wise reversible airflow limitation, whereas COPD, persistent airflow limitation. Asthma, early presentation, COPD, delayed presentation. Even with treatment, asthma will have good response to bronchodilators, COPD, only partial response. Chest X-ray, asthmatics, normal, whereas in COPD, there can be hyperinflated lung fills. And in COPD, most important history is smoking, whereas in asthma, it is the allergy history that is most important. Coming to diagnosis, for COPD, because it is an obstructive lung disease, most important will be spirometry. Now in spirometry, one can notice obstructive phenomena. And in obstructive phenomena, what happens is his FEV1 by FVC will be less than 0.7. And how will it be different from asthma? There will be no significant bronchodilator reversibility. I have discussed spirometry previously. In asthma, there will be good bronchodilator reversibility. Here, there will be no significant bronchodilator reversibility. In COPD, the diagnosis is primarily through spirometry, students. In COPD, diagnosis is primarily to spirometry. Then other blood tests can be helpful. CBC to look for any infection in the patient. Alpha-1 antitrypsin levels. Spirometry we do generally. Gold classification. Gold classifies COPD into 4 stages that I will discuss now. So gold classification. Gold is Global Initiative for Obstructive Lung Disease. Gold means it is a body dealing with COPD guidelines. Global Initiative for Obstructive Lung Disease. GOLD. Now this can be classified into 4 stages. Stage 1 COPD based on gold staging. Stage 3, stage 4. And this stage 1 is called as mild COPD, moderate COPD, severe COPD, very severe COPD. Let it be any stage. Common feature is the ratio will be less, FEV1 by FVC less than 0.7. So this is common feature. Then on what basis is this classified? Stage 1, patient's FEV1 will be more than or equal to 80% of predicted FEV1 of that given age. It is not 80% of FVC, it is 80% of predicted FEV1 of that given age. Whereas stage 2, FEV1 will be 50 to 79% of predicted. Stage 3, FEV1 will be 30 to 49% of predicted. Stage 4, FEV1 less than 30% of predicted. These are the gold classification of COPD. Stage 1, stage 2, stage 3, stage 4. In stage 1, FEV1 can be more than or equal to 80% of predicted FEV1 of that given age. Stage 2, 50 to 79% of predicted. Stage 3, 30 to 49% of predicted. Stage 4, FEV1 will be less than 30% of predicted. Then we can go for lung volumes. If you do a body plethysmography, you can notice in COPD there can be increased residual volume, increased functional residual capacity, increased total lung capacity. All this requires advanced methods such as body plethysmography or helium dilution method. Then in ABG, one can notice decreased PaO2, increased PaCO2. And for excellent visualization of emphysema, HRCT will be helpful. HRCT is excellent tool for visualization of emphysema. Excellent tool for visualization of emphysema. You can see emphysematous changes, you can see bullous. Chest X-ray, I have already told you the findings. Bilateral hyperinflated lung fields, flat diaphragms, tubular heart. HRCT can serve as an excellent visualization tool for emphysema. So these are the basic investigations for COPD. Apart from this, nothing is generally necessary. Do a spirometry. By seeing the FEV1 by FVC ratio, you can diagnose it as COPD. Then blood tests might be helpful to recognize any infection or to look for any alpha-1 antitrypsin deficiency. And if required, lung volumes, residual volume, FRC, TLC by advanced methods such as body plethysmography. ABG, especially during exacerbation, hypoxemia, hypercapnia. Chest X-ray and HRCT. HRCT, excellent tool for visualization of emphysema. And goal classification, stage 1, stage 2, stage 3, stage 4. Then coming to assessment of symptoms in a patient with COPD. For shortness of breath, we have MMRC scale. MMRC scale means Modified Medical Research Council scale. So it is having grades 0 to 4. We have grade 0, grade 1, grade 2, grade 3, grade 4. So I hope we have discussed the grades in basic respiratory symptoms. Grade 0 means patient will say he is breathless only on strenuous exercise. Grade 1 means breathless while walking uphill or hurrying on level ground. Grade 2, patient walks slowly than others due to shortness of breath and cannot catch up with the pace of her contemporaries. Grade 3, patient gets breathless only for walking 100 meters. Short distance patient will get breathless. Whereas grade 4, patient is breathless even while dressing, undressing and unable to leave home. So grade 4 means patient is having breathlessness even at rest. Apart, if you take MMRC scale, it gives only assessment of a patient with COPD with shortness of breath. Now, not just shortness of breath is important, also other symptoms are important for assessment of COPD. For that we have a complete holistic scale called as CAT score. It is a COPD assessment test. In this test, we not only take shortness of breath, we not only take patient's shortness of breath, we also consider patient's cough, patient's sputum production, patient's chest tightness, and also psychological well-being. This CAT score is a complete score, complete assessment of a patient with COPD, and this can also help in predicting mortality. Now what we do in CAT score is we give a proforma to the patient and we ask him to describe his cough, sputum, chest tightness, shortness of breath, psychological well-being. It is just like there will be boxes. 0, it is just like giving rating. 0, 1, 2, 3, 4, 5. So if you ask regarding his cough, but the difference is If patient gives 0 rating, means there is no cough at all. If patients give 5 rating, it means there is significant cough. So he is coughing all during the day. Now next symptom that we take in this scale is sputum. Again the rating will be 0, 1, 2, 3, 4, 5. If patient gives a rating of 0, it means he is not having any sputum at all. If he ticks his rating as 5, it means he is having significant sputum. In between he can rate whether it is 1, 2, 3, 4. See, just like you give rating to a movie, you give rating to an app. But here more rating means more danger to the patient. Less rating means patient is more comfortable. This is the basic COPD assessment test. Like I told you, we consider patient's cough. So first parameter is the cough. And we ask the patient to give rating. Is it 0, 1, 2, 3, 4, 5? If he ticks 0, it means he doesn't have cough at all. If he ticks 5, he is having cough all the time. So this is the first parameter where we target patient's cough. Second parameter is what we target patient's sputum production. So it will be written as in the proforma. I have no mucus in my chest at all. Whereas 0 is no mucus. 5 means my chest is fully filled with mucus. And third, we take patient's chest tightness. Whether he is not having chest tightness or whether patient is having significant chest tightness. And 4, 5, we take patient's shortness of breath. In 4, patient, you ask him whether you are having shortness of breath on climbing stairs. If he says he is not having 0. If it is 5 means when he walks uphill or one flight of stairs, he is very breathless. And 5, is he limited doing any activities at home? 0, no limitation. 5, significant limitation. Now 6, 7, 8. We take patient's psychological condition, psychological well-being. So in the 6, patient says if at all he is very confident leaving his home, he gives 0. I am very confident, no issue. If he says 5, he is not at all confident. It means more severe impairment. I sleep soundly, no sleep disturbance. Significant sleep disturbance is 5. Patient feels he is having lot of energy, emotional well-being. If he is emotionally well, 0. If he is depressed, emotionally unwell, score will be 5. Score will be 5. This is the COPD assessment test. What we do is, in MMRC scale, we only consider shortness of breath. Here we consider patient's cough, patient's sputum, chest tightness, patient's shortness of breath, and emotional well-being. And we give total score. Generally, CAT score less than 10 is considered patient is not having significant impairment. If patient is having CAT score more than 10, it usually indicates patient is having significant impairment due to the disease. So if CAT is less, it means patient is not having significant impairment due to the disease. If CAT is more, patient is having significant impairment due to COPD. If they ask you COPD assessment test, it is a rating system 0 to 5, which includes holistic assessment of patient's symptoms such as cough, patient symptoms such as sputum, chest tightness, shortness of breath, and psychological well-being, whether the patient is confident leaving home, whether the patient feels he is having good energy, whether the patient has slept soundly. If this CAT score is more than 10, it indicates patient is having significant impairment due to the disease. Now coming to treatment. In the treatment, most important will be smoking cessation, because smoking is responsible for all these pathophysiological phenomena. Most important will be smoking cessation. Coming to pharmacological treatment. Now the pharmacological treatment is very important. The reason is this is a long-standing disease. Patient should get long-standing medication. Now, which bronchodilators will be helpful to relieve his symptoms? See, bronchodilator should be given to this patient. Is it long-acting or short-acting? Logically, this is a persistent disease. Long-acting bronchodilators will be helpful. LABA, LAMA. I think most of you must be knowing what are LABAs. Salmeterol, formoterol. Whereas LAMAs, we have tiotropium, long-acting muscarinic antagonist. Tiotropium, umeclinidium, glycopyrronium. Recently, we are having ultra-LABAs. The advantage of ultra-LABAs is once daily dose. Whenever I give salmeterol or formoterol, it acts only for 12 hours. So patient has to take twice. Whereas ultra-LABAs, the duration of action is 24 hours. And ultra-LABAs available currently in the market, Indian market, indaketrol, vilanterol, olodetrol. Then in pharmacological therapy, apart from bronchodilators, next important will be steroids. Now these steroids can either be given as systemic form, tablet injections, or inhaled form, inhaled corticosteroids. These systemic forms are helpful during exacerbations. See, whenever patient is continuously smoking, there can be inflammatory exacerbation, smoking related inflammation and worsening. To bring down that exacerbation, you can use systemic corticosteroids. Once the patient recovers from an exacerbation, he is at risk of another exacerbation. To decrease frequency of exacerbation, inhaled corticosteroids can be given. Now if they ask you, out of these bronchodilators, which is most preferred bronchodilator in COPD, your answer should be LAMA. In asthma, it is LABA. In COPD, it is LAMA. So the reason is, studies have shown that this LAMA not only causes bronchodilation, because of some indirect mechanism, it can decrease smoking related inflammation. Whenever they ask you in COPD, preferred bronchodilator is LAMA. The reason is, it not only causes bronchodilation, it can indirectly decrease smoking related inflammation overall, which can decrease exacerbation in the patient. The next important drug in COPD, mucolytics. Now these mucolytics not only breaks the mucus and facilitates expectoration, such as N-acetylcysteine. So they are also having antioxidant property. This N-acetylcysteine has antioxidant property and it can fight against the oxidative stress in COPD. We know that in COPD, because of smoking, because of pollutants, there can be increased oxidative stress and release of free radicals. So this mucolytics will not only break down the mucus. Mucolytics such as N-acetylcysteine has also antioxidant function, which can decrease oxidative stress. Then we have selective PDE4 inhibitor. Such as roflumilast. And this roflumilast is also having anti-inflammatory action. So this can be given to decrease frequency of exacerbation. Then what are the role of antibiotics? Nowhere in asthma exacerbation I have discussed about antibiotics. Because asthma exacerbation generally allergen. If at all it occurs due to infection, it is generally due to rhinovirus. Rhinovirus is common cold virus. No need to give any antibiotic for common cold virus. But COPD, whenever infective exacerbation happens, it can be due to bacteria. During exacerbations, antibiotics are given. And most common bacteria isolated is Haemophilus influenza. And recently, these patients with COPD are also given azithromycin prophylaxis, because these patients are at risk of developing another infection after few months, to bring down the exacerbation frequency. Now this azithromycin is having two roles. It is not just anti-infective, it is also anti-inflammatory. It can decrease the infective exacerbations and also inflammatory exacerbations. So keep this in your mind, students, whenever you are prescribing drug therapy to COPD. What are the drugs that should be included? Bronchodilators. And depending upon patient's exacerbation status, you can give inhaled steroids. And mucolytics definitely required. And where to use this azithromycin, where to use this roflumilast, I'll tell you shortly. But definitely to be given will be bronchodilators. So routinely for a COPD patient, you can prescribe bronchodilators, you can prescribe mucolytics. Let us see what is Gold 2021 telling about bronchodilators, steroids, antibiotics. This bronchodilators, no need to write all this. You write only the one I have written in this red box. Others, I'll just read it out for you to understand, that's all. Bronchodilators can improve FEV1. It can reduce symptoms and it can give protection against exacerbations. Now what is the preferred bronchodilator? Is it a single bronchodilator? Bhattacharya, criteria for COPD exacerbation. We are having a separate topic. What is COPD exacerbation? So there I will discuss. Okay. Bronchodilators can improve FEV1, reduce symptoms and exacerbations. Now what does the evidence says that? Any bronchodilator can be used, either LABAs or LAMAs. And if they ask you which is better, LAMA is better than LABA. See, this is the current guideline. LAMA plus LABA is better than only LAMA. It is only LAMA, and LAMA is better than LABA. So this is the current prescription guidelines. So whenever you are thinking to give bronchodilators in COPD, depending upon patient symptoms, this is the order of preference. And how to prescribe this also, I will let you know. See, LAMAs have greater effect on exacerbation. And combination therapy, LABA and LAMA increases FEV1 when compared to monotherapy. Combination therapy, LABA, LAMA reduces exacerbations compared to monotherapy. Tiotropium improves the effectiveness of pulmonary rehabilitation in increasing the exercise performance. On the whole, what the guidelines say is, when you give bronchodilators, there will be increase in FEV1. Patient symptoms can reduce and exacerbations can reduce. And if they ask you what is the best combination, it is dual therapy, LAMA plus LABA. And if you want to give single drug, what is better? LAMA. Last will be LABA in COPD. And how much azithromycin will be helpful for prophylaxis? In whom it should be given, I'll tell you shortly. Whenever you are thinking of azithromycin prophylaxis, this is from Gold 2021. You can give either 250 mg per day or 500 mg thrice a week. We generally prefer azithromycin only for 1 year. So it should be given for 1 year. Either 250 mg OD every day or 500 mg OD on alternate days for 1 year in patients prone to exacerbations. Now where to use this azithromycin? where to use this monotherapy, where to use this combination therapy, I'll tell you in a while. This is regarding medical management. In medical management, we have bronchodilators, we have steroids, we have mucolytics, we have PDE4 inhibitors, we have antibiotics. Then coming to oxygen. When the patient develops hypoxemia, you should give long-term oxygen therapy. Long-term oxygen therapy. Long-term oxygen therapy, what are the indications? Indication number 1, if patient's resting PaO2, if patient's resting PaO2 is less than 55 mmHg. Now patient's PaO2 is less than 55 mmHg, he has developed COPD, you should give him continuous oxygen. Or patient's resting PaO2 has not fallen down to 55. It is in the range of 55 to 59 mmHg, but with end organ complication such as signs of right ventricular dysfunction. Patient might be having edema, patient might be having pulmonary hypertension. So if a patient has coexisting complication, start oxygen early, 55 to 59 mmHg. If patient is not having any other coexisting complication, so you start oxygen at PaO2 less than 55 mmHg. Resting PaO2 less than 55 mmHg or PaO2 55 to 59 mmHg if patient is having any signs of right ventricular dysfunction. If patient is having any coexisting complication, start oxygen bit early. If patient is not having any coexistent complication, you can start oxygen PaO2 less than 55 mmHg. And for how many hours oxygen should be given? And majority of the patients also, they just keep oxygen for 4 or 5 hours and they come back to me, sir, we have brought oxygen, we are using it, there is no benefit. Guideline says that it is 15 hours per day, at least 15 hours per day. At least 15 hours per day you should give oxygen. When you say patient can get benefit from oxygen, you should give 15 hours per day. And this patient should undergo pulmonary rehabilitation. These are set of measures which can improve the outcome of a patient with COPD. In pulmonary rehabilitation, we ask the patient, we teach him some breathing exercises, mucus clearance mechanism, so that there will be breathing with less use of energy, and also mucus clearance that can give patient better comfort. So pulmonary rehabilitation or a set of techniques advised to the patient to improve his performance. Then surgical intervention, we can go for bullectomy. You know that in COPD there are hyperinflated areas called as bullas. These bullas actually don't take part in gaseous exchange. They can compress the diaphragm, compress the adjacent lung, and they can result in impairment of respiratory mechanics. So this surgical intervention, bullectomy, so these are done to improve respiratory mechanics. And whenever there are no clear-cut bulla but hyperinflated areas, there you can go for lung volume reduction surgery. So you can reduce the volume of lung by removing that hyperinflated areas. Nowadays we are having, there are two types. So surgical lung volume reduction surgery, and we are also having bronchoscopic lung volume reduction surgery. Through bronchoscopes, we are going to insert a few instruments, so coils or valves, and we will stop gas flow to that area so that it will not expand. Now these hyperinflated areas will not take part in gaseous exchange, but they can apply weight on the adjacent lung, not allowing its function properly. Now if everything fails, this patient is a candidate for lung transplant. Surgical intervention, if there are visible bullas, we can go for bullectomy. If there are no bullas, only few hyperinflated areas, we can go for lung volume reduction surgery to decrease the compression on healthy lung to improve respiratory mechanics. Lung volume reduction surgery, we have a surgical method, surgical lung volume reduction surgery, or through bronchoscopy. By putting a few devices in that segments, we decrease the air entry into that segments, not allowing it to expand further. Then these patients should be advised to vaccination. And definitely what vaccination? Every year influenza vaccine. If they have not taken pneumococcal vaccine, they should take pneumococcal vaccine. And recent evidence says that all patients with the COPD aged less than 65 years should get pneumococcal vaccine. Generally, after 65, we give pneumococcal vaccine to all population. Now, there is a patient aged 19 to 65. He is with COPD. In that age, what should be given? You should give a pneumococcal polysaccharide vaccine. Pneumococcal polysaccharide vaccine containing 23 strains. So it is PPSV 23. It is PPSV 23. It is available as Pneumovax 23. Pneumovax 23. If somebody wants the trade name for this, it is available as Pneumovax 23. Now influenza, you are having 4 strains. It is available as quadriflu, flu quadri. So this everybody should get. Even we should get vaccinated with influenza every year. Whereas pneumococcal vaccine, it should be given to 19 to 65 years people who are with COPD. And age more than 65, everybody should be given pneumococcal vaccine. And if everything fails, this patient is a candidate for lung transplant. If everything fails, patient is a candidate for lung transplant. Right now, most common indication for lung transplant worldwide. Most common indication for lung transplant worldwide. First is ILD, second is COPD. And in which COPD you should go for lung transplant? We are having a separate topic on lung transplant in this series of lectures. In that lecture, I will tell you what are the criteria for lung transplant, what are the complications, that everything. There is a separate topic on lung transplant. There I will discuss. Most common indication for lung transplant right now is ILD followed by COPD. So this is the basic management, students. Whenever a patient with COPD reaches you, you should advise smoking cessation first. And pharmacological therapy, what you can prescribe: bronchodilators, mucolytics. And later steroids, PDE4 inhibitor and antibiotics. There are separate criteria that I will tell you in a short while. Then if the patient's resting PaO2 is less, you can go for long-term oxygen therapy. And pulmonary rehabilitation, surgical intervention if there are visibly big bullas. And what are the vaccinations that you should advise any COPD patient? Every year, quadriflu. And once in life, you should advise him pneumococcal vaccine. And if everything fails, this patient is a candidate for lung transplant. What are the other rare pharmacological managements in COPD given by Gold 2021? So this everything is from Gold 2021. If at all patient is having alpha-1 antitrypsin deficiency, there is a therapy called as intravenous alpha-1 antitrypsin injection. So you can give alpha-1 antitrypsin injection. And can I give cough syrups in COPD? There is no conclusive evidence. No conclusive evidence. And any evidence for vasodilators in COPD? No. Vasodilators do not improve outcomes and sometimes they can worsen oxygenation. Other pharmacological managements, you can give alpha-1 antitrypsin augmentation therapy. Whenever there is documented alpha-1 antitrypsin deficiency, there you can give intravenous augmentation therapy to slow down progression of emphysema. Whereas antitussive vasodilators are not helpful. Now for COPD, there is a new algorithm called as COPD ABCD assessment. This is based on a graph, students. In the graph, on the horizontal axis, we take patient's symptoms. In the vertical axis, we take patient's exacerbation history in last 1 year. Just like in asthma, we have stepwise management. Step 1, step 2, step 3, step 4, step 5. For COPD, we are having group-wise management. This is the new classification, COPD ABCD assessment. Symptoms, I am going to divide it into two. Patients with less symptoms, less impairment. Less symptoms in the sense, patient's breathlessness will be of less grade, 0 to 1. And the CAT score generally will be less than 10. Whereas opposite, more symptoms, MMRC more than or equal to 2. From here onwards, patient is having significant breathlessness, and CAT score here generally will be more than 10. And coming to exacerbation history. In the last 1 year, patient had 0 or 1 non-severe exacerbation. Whereas here, more than 1 non-severe exacerbation or more than or equal to 1 severe exacerbation. Severe exacerbation means which is resulting in hospitalization, especially ICU admission. So we have divided symptoms into 2, exacerbations into 2. Now what I am going to do is, I am going to draw a straight line, perpendicular line to divide symptoms into 2. Another perpendicular line to divide exacerbations into 2. Now by this classification, you are getting 4 blocks here. So this is named as, with simple alphabets, Group A, Group B, Group C, Group D. Now tell me, students, with the simple common sense, out of these 4 groups, which will have good prognosis? We are having 4 compartments. Which compartment will have good prognosis? Green badge to Group A, because patient is having less impairment, less worsening. So generally these patients will have good prognosis. Group A. Patients belonging to Group A will be usually having good prognosis. Then which will be having worst prognosis? Out of these 4 groups, it is usually Group D, because patient is having more symptoms and more worsening. So these patients usually have worst prognosis. Now the main goal of this COPD ABCD assessment is to identify these Group D patients early and to provide them very best treatment, to provide them all the treatment options. Identify Group D early and treat them adequately. Let us see the treatment options. When there is a patient with COPD, you have to classify him like this. Is he belonging to Group A, Group B, Group C, Group D? Now if he belongs to Group A, here treatment, a single bronchodilator will be sufficient. Apart from this, nothing is required. Smoking cessation, bronchodilator. Here initially we can give a short acting bronchodilator, initial COPD. But usually none of the patient will present to me as Group A. Group B, here definitely you should give long acting bronchodilator. Long acting bronchodilator, either LAMA or LABA. From Group C onwards, you should give most preferred bronchodilator, that is LAMA. In Group C, patient even though is having less symptoms, but he is having worsening exacerbations. So there you give LAMA. Whereas Group D, here you should start the most effective bronchodilator called as LAMA first. And you should constantly monitor the patient, because this is the group which can worsen. And even after starting LAMA, patient's symptoms have not decreased. If a patient symptoms not improving, if patient symptoms are not improving, now what you need to do is you have to make it dual bronchodilator. Here you should give dual bronchodilator, LAMA plus LABA. Now you have started the LAMA. Now recent studies have shown that one reason for frequent exacerbation in COPD is pre-existing history of asthma. If patient is having history of asthma, or you can indirectly know it by blood eosinophils more than 300 per mm³. Now one reason for worsening of this COPD patient is his pre-existing asthma or blood eosinophils, which can indirectly be known by blood eosinophils more than 300. So in this patient you should address asthma issue predominantly. So you can change the medication to LABA plus ICS. Now let it be with any of this medication. If patient is not improving, either this patient is developing exacerbation, or on this side this patient is developing more symptoms. Now in this situation what you do is you have to advise triple therapy, LAMA plus LABA plus ICS, and in this group D, according to patient situation, you can consider roflumilast. You can also consider azithromycin prophylaxis. As a rule, generally I give roflumilast and azithromycin if eosinophil counts are low. If the asthma because these roflumilast and azithromycin ultimately function as anti-inflammatories. I generally do not combine steroid and azithromycin. We don't combine generally steroid and roflumilast. Now if I feel this patient is not this eosinophilic type, I can either go for roflumilast or azithromycin. Generally roflumilast is given in chronic bronchitis predominant, because roflumilast has a bad side effect called as weight loss. If you give it in very lean patient, already that patient is having muscle loss, and that will not be good for that patient. And roflumilast generally given for patients with chronic bronchitis predominant. And azithromycin prophylaxis, it can be given for emphysema predominant patients without eosinophilic inflammation. So this is the final pathway. In group D, you start LAMA. If patient symptoms are not improving, you can give LAMA plus LABA. And one reason for group D patient to develop frequent exacerbations, it might be due to patient's previous history. As for any history of asthma, or look at his blood eosinophils. If any one is positive, either patient is having asthma history or eosinophils are high, you can give him LABA plus ICS. And the final pathway, if patient is not improving on LAMA or LABA plus ICS, you can go for LAMA, LABA plus ICS. Still patient is not improving, you may need to consider other options such as roflumilast, which I generally give it in chronic bronchitis patient, and in azithromycin, we usually give it in azithromycin prophylaxis, we generally give it in emphysema patient. So this is the treatment for COPD Goal 2021. So here I have shown you where I should give inhaled corticosteroid, where I should add roflumilast, where I should go for azithromycin, where I should use single bronchodilator, where I should go for combination, where I should go for triple therapy, LAMA, LABA, ICS. So this will be the treatment protocol of Goal 2021. Any relationship between FEV1 and roflumilast? FEV1 less than 50%. See, usually these patients with group D, in group D, their FEV1 generally will be less than 50%. So less than 50% FEV1, but very less FEV1, again in exacerbation you should not give this roflumilast. In exacerbation it is not included. It is not included in exacerbation. That also I will tell you, don't worry. Now these are the non-pharmacological management of COPD. Now if the patient is belonging to group A, apart from the pharmacological management, smoking cessation, physical activity, flu vaccination, pneumococcal vaccination. From B, C, D, like I told you, smoking cessation is very important. Flu vaccination, pneumococcal vaccination is very important. And pulmonary rehabilitation, you can start from B, C, D. Pulmonary rehabilitation in B, C, D can be started. Pulmonary rehabilitation in B, C, D can be started. So this will be the non-pharmacological. Apart from giving drugs, if patient is belonging to group A, so you should advise him smoking cessation. You should advise him physical activity. You should give him pneumococcal vaccination. If patient is belonging to group B, C, D, along with this, you should refer him to pulmonary rehabilitation. Students. Pulmonary rehabilitation. So these are the various drugs that will be helpful. So I hope you have understood where to use single bronchodilator, dual bronchodilator, where to use roflumilast. So roflumilast generally given in group D patients, not improving with triple therapy, and roflumilast is generally given in chronic bronchitis patients, and usually, as Pallav Bhattacharya was asking regarding FEV1, these patients will be generally having FEV1 less than 50%. But there is no point in giving roflumilast in exacerbations, we avoid. So we give it in group D, and azithromycin prophylaxis, we give it in emphysema predominant patients generally. Then next, coming to what is meant by COPD exacerbation. So any worsening of COPD, it is called as exacerbation. So worsening in the sense, patient can complain of increased shortness of breath. Patient can complain of increased purulence of secretions. Any worsening of COPD, such as increased shortness of breath, increased purulence of secretions. These are the important features: increased shortness of breath, increased purulence of secretions. Any worsening of COPD, it is called as exacerbation. Now, can anybody tell me, whenever there is a COPD exacerbation, what might be the differential diagnosis? Don't think a patient with COPD will only have COPD exacerbation and treatment is only bronchodilator. And COPD patient can also worsen, not just due to worsening of the long-standing COPD, he can also be having a new diagnosis. So can anybody tell me, if at all COPD patient is in the emergency department and he has worsened, apart from thinking it as worsening of the long-standing disease, what are the differential diagnoses? Don't forget to evaluate for pneumothorax. Patients with COPD can develop pneumothorax. Don't forget to evaluate for pulmonary embolism. Don't forget to evaluate for any pleural collection. pleural collection. Especially patients with COPD, they might have long-standing infections. They can develop effusions or pus, empyema. And don't never forget to evaluate for any pulmonary edema due to myocardial infarction or any pneumonia. And finally, COPD patients are also prone for arrhythmias. So when there is a patient with COPD, apart from thinking of worsening of pre-existing lung disease, also think of any possibility of pneumothorax, possibility of pulmonary embolism, pleural collection, pulmonary edema due to MI, pneumonia, arrhythmias. Now if you think it is pneumothorax, apart from clinical examination, decreased breath sounds, hyper-resonant note, you need a chest X-ray. For pulmonary embolism, for diagnosis, you might need D-dimer. You might need to refer to CT pulmonary angiography. For pleural collection, chest X-ray, USG chest. And pulmonary edema due to MI, ECG, 2D echo. And for documenting pneumonia, chest X-ray and arrhythmias, ECG. So whenever a patient with COPD worsens, apart from thinking of it as routine exacerbation, think possibility, rule out possibility, whether there can be pneumothorax. If it is not improving with the bronchodilator, still patient is having significant breathlessness. Think in terms of pulmonary embolism. Think in terms of pleural collections. Think in terms of pulmonary edema due to MI. Don't just keep on dumping him nebulization. If it does not improve within 20 to 30 minutes, think of these possibilities also. Pulmonary embolism, pulmonary edema, pneumothorax, pleural collection, pneumonia, arrhythmias. So these are the differential diagnosis of a patient with COPD exacerbation. And even GOLD, this is a table from GOLD 2021. This also mentions this same. Don't forget about pneumonia, pneumothorax, pleural effusion, pulmonary embolism, pulmonary edema due to myocardial infarction, cardiac arrhythmias. When a patient with COPD is not improving in the emergency department, apart from thinking it as just a simple exacerbation, think of these conditions also. Then coming to what are the indications for hospitalization assessment. Now these are the important features of exacerbation. Patient can have worsening of resting dyspnea, high respiratory rate, decreased oxygen saturation, confusion, drowsiness. Now if these signs are there, this patient might require hospitalization. Patient is in respiratory failure and there are onset of new physical signs, cyanosis, peripheral edema. Patient is not responding to initial management or patient is having presence of serious comorbidities. You can see majority of COPD is coming in early morning or midnight, having nebulization and going back home. But few patients might require hospitalization. Whom you should hospitalize? These are the indications for hospitalization in COPD exacerbation. Patient with severe symptoms such as dyspnea, high respiratory rate, decreased oxygen saturation, acute respiratory failure, onset of new physical signs, failure of an exacerbation to respond to initial management, presence of serious comorbidities such as heart failure, newly occurring arrhythmias. If you find any one of this, clinically or radiologically or on ECG, you should ask the patient to stay in hospital. Then what is the treatment? Treatment in COPD, primary treatment, you should give oxygen and nebulized bronchodilators. We can give SABA, SAMA. And this patient requires systemic steroids. equivalent to 1 mg per kg body weight prednisolone. And usually in an exacerbation, we give steroid for 7 to 10 days. No point in increasing beyond that. Then this patient requires antibiotics. And general antibiotics will be beta-lactams. I told you, a COPD exacerbation can be due to what? It can be due to an infection. To counter that infection, you might need to give beta-lactam. And if patient not improving with simple oxygen, patient might require NIV, mechanical ventilation. If not improving, patient require non-invasive ventilation. Non-invasive ventilation, and generally we go for BiPAP. So why we prefer non-invasive ventilation? Because in COPD, already there are hyperinflated areas called as bullas. If you give invasive ventilation, that positive pressure is directly going into the lung. And whenever a balloon which is already stretched to its maximum capacity, if you give directly air into that balloon will rupture. In the same way, if bullas rupture, there will be increased risk of pneumothorax. This NIV is having decreased risk of pneumothorax, and moreover you are not putting any tube. There will be decreased ventilator associated pneumonia here. Ventilator associated pneumonia. Already patient with COPD, lung condition is bad. In that, if any new infection develops, he will become worse. And finally, if not improving with NIV, you might need to go for invasive mechanical ventilation. But when you go for invasive mechanical ventilation, there is risk of pneumothorax, risk of ventilator associated pneumonia, and increased chances of mortality. This will be the management of COPD exacerbation. Initially you should give oxygen, bronchodilators, systemic steroids, antibiotics definitely given. And if the patient is not improving, there are few indications for NIV that I will just discuss. Not improving with oxygen, you can go for NIV. Even if the patient is not improving with NIV, only as a last resort, we give invasive mechanical ventilation. Why don't we prefer invasive mechanical ventilation as first line ventilatory management in COPD? Because invasive mechanical ventilation has a high risk of pneumothorax. Invasive mechanical ventilation has a high risk of ventilator associated events. To avoid this, we are giving NIV first. If patient is not improving with NIV, then only I go for invasive mechanical ventilation. So this is what Gold 2021 also says. Gold 2021 also says, see, you should give bronchodilator, you should give steroids and antibiotics. Non-invasive ventilation is first, and theophylline are not recommended. And regarding steroids, so Gold 2021 says 5 to 7 days, but there are other guidelines which says it can be given maximum 10 days, but beyond that it should not be given. So it is 7 to 10 days. You can remember it as 7 to 10 days. Generally, we try to complete it within 1 week. In few, it might be extended to 10 days, but no point in giving beyond 10 days. What should be given in COPD exacerbation? Only this. Bronchodilators, see SABA or SAMA, systemic corticosteroids, antibiotics, and ventilation, non-invasive ventilation. Then what are the indications for NIV? When you should start NIV? When patient is having any one of the following, at least one of the following. Patient is having respiratory acidosis. When do you call it as respiratory acidosis? PaCO2 more than 45 mmHg and pH is less than 7.35, and patient is having severe dyspnea. So there is increased work of breathing. If there is increased work of breathing, after some time the respiratory muscles will become fatigued. That will result in decreased respiratory effort. Severe dyspnea with such increased work of breathing, respiratory muscle fatigue, and the use of accessory respiratory muscles, paradoxical motion of abdomen. So abdomen is not working. Why there is paradoxical motion of abdomen? Because diaphragm has become weak. Diaphragm is not working properly. Retraction of intercostal spaces. All this indicates there is severe respiratory distress. And even if you give oxygen, not improving with oxygen, persistent hypoxemia, very low saturation. See, if it is 88 to 92, no need to worry. Persistent hypoxemia, saturation is still 75%, 70%. At least one of the following. Most important is respiratory acidosis. Second, increased work of breathing. Not improving oxygen with supplemental oxygen, even after giving oxygen. 3 indications, any one. Either respiratory acidosis, increased work of breathing, and persistent hypoxemia. So in short, you can remember like this. Persistent hypoxemia. 3 important features, any one of the following, either respiratory acidosis, increased work of breathing, persistent hypoxemia despite supplemental oxygen. Now these are the 2 methods of mechanical ventilation. Can you tell me what is A and what is B? What is A? In the image A, this is ventilator and it gives positive pressure ventilation. Now how is it given through? It is given through an endotracheal tube. Such type of mechanical ventilation is called as invasive mechanical ventilation. Such type of mechanical ventilation is called as invasive mechanical ventilation. Whereas 2, this is a ventilator, this will give positive pressure ventilation and it is given through a face mask. And this type is called as non-invasive ventilation. Non-invasive ventilation. This is non-invasive ventilation. Whenever you are starting non-invasive ventilation to any patient, first prerequisite, patient should be conscious, coherent. You cannot give NIV in unconscious patient. So why I cannot give NIV in unconscious patient? The reason is simple. Unconscious patient, their cough reflex will be completely gone. There will be lot of secretions pulled up in the oral cavity. Now if you seal their face with a face mask and give positive pressure, all those secretions can go into the lung and patient can die of asphyxiation. Again we will be having special session on mechanical ventilation. There I will discuss the modes, the mechanism of action. Now just practical points. You can give NIV in anybody except these people. There are few contraindications in whom NIV is contraindicated. First, unconscious patient. No point in giving unconscious, risk of aspiration. Altered sensorium. Patient with altered sensorium will also have altered cough reflex. And third important point, uncooperative patient. If patient is not cooperative, he can pull out the mask. Now can you give invasive mechanical ventilation in uncooperative patient? Yes. Because when I give IMV, I am completely sedating the patient, knocking him down. There is no point of cooperation or uncooperation. He has to bear with it. But whereas in NIV, I cannot give excess sedation. If I give excess sedation, there can be CNS depression, unconsciousness, poor cough reflex. Again, there can be aspiration. Don't give it in patient with cardiac arrest. Cardiac arrest itself means patient is unresponsive, unconscious. Again, there is no point in giving NIV in unconscious patient. Hemodynamically unstable patient. hemodynamically unstable patient. Whenever a patient is hemodynamically unstable, he can develop cardiac arrest at any point. Whenever there is cardiac arrest, again patient cannot be on NIV. So in hemodynamically unstable patient, we avoid. Recent nasal surgery. Now if you notice here, you give not only pressure through the mouth, you also give it through the nose. Now if the patient had some recent nasal surgery, this positive pressure can go into the nose and can damage the surgical wound. Whenever surgical wound is damaged, there can be torrential bleed and active GI bleed. When a patient is having active GI bleed, if he has blood vomiting and you have sealed his face, now that vomitus cannot go out. It can go back into the lungs and patient can die of asphyxiation with blood clots. So these are a few contraindications, NIV contraindications. Now I'll give you a scenario. Scenario 1, scenario 2. Tell me what is the preferred method of mechanical ventilation. There is a patient with COPD, type 2 respiratory failure. He was found unconscious. Now what is the type of mechanical ventilation? Tell me students. What will you do here in scenario 1? There is a patient COPD, type 2 respiratory failure. When you see these two things, you will be definitely attracted to NIV. But this patient is unconscious. When the patient is unconscious, no point in giving NIV. You should directly go for IMV. Second scenario, COPD, type 2 respiratory failure and patient is conscious. See, type 2 respiratory failure means hypercapnia. See, when I say type 2 respiratory failure, see, type 1 means hypoxemic respiratory failure. Type 2 respiratory failure means hypercapnia. See, in COPD there will be increased CO2, hypercapnia. You can consider type 2 means hypercapnia. Now in this patient is having COPD, type 2 respiratory failure and he is conscious. What will be the preferred method of mechanical ventilation? NIV. So this is an ideal situation to start NIV. And don't have that rigid thinking that COPD patient only I should give NIV. It depends upon the patient's present clinical scenario. If patient is in unconscious, altered sensorium, there is no point in giving NIV. It will be more harmful. There you should definitely do IMV. Now that's why I have also included this slide. What are the indications for invasive mechanical ventilation? What are the indications for invasive mechanical ventilation? So when you should intubate him? He is unable to tolerate NIV, cardiac arrest, altered sensorium. See here, what are all the contraindications I have discussed there. This has been put as indication for invasive mechanical ventilation, nothing new. And massive aspiration or persistent vomiting, hemodynamic instability, and this instability can be due to arrhythmias, and life-threatening hypoxemia, uncooperative patient, he is unable to tolerate NIV, and his persistent inability to remove secretions. So patient might be having poor cough reflex. See, whatever I have mentioned as contraindications, for NIV, that will become indications for IMV. Unable to tolerate, patient is in respiratory or cardiac arrest, diminished consciousness, altered sensorium, unconsciousness, massive aspiration or persistent vomiting, persistent inability to remove respiratory secretions, severe hemodynamic instability without response to fluids and vasoactive drugs, severe ventricular or supraventricular arrhythmias, life-threatening hypoxemia in patients unable to tolerate NIV. In simple words, what are all the contraindications of NIV? it will become indications for IMV in COPD. And finally, these are the interventions that reduce frequency of exacerbations. So if they ask you in COPD, what are the drugs that you should generally prescribe? So we should give bronchodilators. We can give steroids, and we can give anti-inflammatories, anti-infectives, mucoregulators, and others. All this can decrease COPD worsening. So all these drugs, they can decrease COPD worsening. They can decrease COPD worsening. And you know when to give monotherapy, when to give combination therapy. And you also know when to give LABA plus ICS. In group D, if the patient is having previous asthma history or more eosinophils. And when to give triple therapy. In whom you should prescribe roflumilast. Group D patients not improving with triple therapy. Chronic bronchitis predominant, roflumilast. And vaccines, it should be given in all A, B, C, D. Yearly you should give influenza vaccine. And once in life you should give a pneumococcal vaccine. And long-term antibiotics. Again, this is also helpful in group D. Patient not improving with triple therapy, you can add long-term macrolide. And mucoregulators, N-acetylcysteine, not just for their mucolytic property, it is useful for its what property? Antioxidant property, various other, smoking cessation, rehabilitation, lung volume reduction, and this is new addition. Vitamin D supplementation. So why vitamin D supplementation? Vitamin D supplementation can improve lung function. So tomorrow in your practice, whenever you see a patient with COPD, think about these drugs to prescribe. So what bronchodilator I should prescribe? Should I prescribe steroid? Should I prescribe roflumilast? Should I prescribe vaccination? Should I prescribe mucolytics? Should I tell anything else? Yes, definitely most important is smoking cessation. Apart from that, rehabilitation. And if the patient is having large bullets, you can also advise him for lung volume reduction. And this will be the interventions that will reduce frequency of COPD exacerbation. The interventions that will reduce frequency of COPD exacerbations. Before we conclude, just give me 10 minutes because there is a new topic called as asthma COPD overlap. There can be few patients who are having both features of asthma and COPD. Just we will discuss. This can also be asked as an essay question for you. This is asthma, ACO, asthma COPD overlap. This is called as ACO. These patients will be having persistent airflow limitation with several features associated with asthma and few features associated with COPD. It is just like patient is having both these phenomena. Patient is having persistent airflow limitation with several features usually associated with asthma and several features usually associated with COPD. Then there can be two possibilities. Either there was an asthmatic, he can become asthmatic, can later develop, two possibilities, later develop COPD, and this is more common, asthma COPD overlap, or rarely a COPD patient can later develop asthma features. This is bit rare. Either a patient with asthma after getting exposed to smoke pollution can develop COPD. Now he will have both components, asthma component, COPD component. Or COPD patient also can develop airway hyperresponsiveness, having features of asthma. So these are the two situations. Common is this, asthma patient getting exposed to smoke, pollutants, developing asthma COPD overlap. Now say there is a patient with asthma. There is a patient with asthma. Now this patient is exposed to these things. He is exposed to smoking. Now because of smoking, as a part of inflammation, there will be increased interleukin 6, interleukin A, interleukin 17A, and pollution. Because of pollution, there can be oxidative stress and altered DNA methylation, and also recurrent exacerbations. Now asthma patient frequently is worsening because of that inflammation and activation of proteases. Proteases are nothing but elastases. Now when an asthmatic is getting frequent exacerbations, within his lung there will be activation of elastases. Either he is exposed to smoke, either he is exposed to pollutants or frequent exacerbations. So this will result in few changes. So what are the changes? Now because of smoking, these cytokines, they can result in development of Th1 inflammation characterized by neutrophils, COPD type inflammation. See, asthma inflammation up to then was Th2. Now this can result in Th1 inflammation, increase accumulation of CD8 T cells, and also goblet cell metaplasia, and neutrophilic inflammation, neutrophilic smooth muscle hyperplasia. And because of elastasis, there will be loss of lung recoil. So all this will contribute to development of COPD. So this will result in development of COPD. This is how a patient with asthma can develop COPD features. The reason is because of his smoking habits, pollution, and recurrent exacerbations. There can be COPD type inflammation. It can be Th1 inflammation, increased CD8 T cells will be there, goblet cell metaplasia will be there. Goblet cells are nothing but mucus producing cells. There can be neutrophilic smooth muscle hyperplasia, neutrophilic inflammation, and these elastases can destroy the elastic fibers, resulting in emphysema changes. So this is how a patient with asthma is going to develop COPD features. Now this patient is having asthma and both COPD. So it was called as asthma COPD overlap. This is how asthma becomes asthma COPD overlap. Exposure to smoking, pollutants, recurrent exacerbations. That results in Th1 inflammation, increased CD8 T cells, goblet cell metaplasia. There can be loss of lung recoil due to elastase mediated destruction of elastic fibers, neutrophilic smooth muscle hyperplasia. Neutrophilic smooth muscle hyperplasia. But very rarely a patient with COPD can also behave like asthma. He can develop airway hyperresponsiveness. Now because of lung elastic forces, now high airway hyperresponsiveness is nothing but your airways are getting closed because of some allergen mediated inflammation. Now here also what happens is because these elastic fibers are lost, they have been destroyed in COPD, his airways will also react excessively. So there can be airway hyperresponsiveness in COPD. Because of destruction of elastic fibers, these airways can become very responsive to allergens. There can be loss of lung elastic forces resulting in airway hyperresponsiveness. So this is bit rare. A patient with COPD developing asthma features is rare, but an asthma patient can develop COPD features, that is common. Asthma becoming asthma COPD overlap is common. Then coming for diagnosis, we need 3 major criteria plus 1 minor criteria. So what are the major criteria? First we will see what are the major criteria for diagnosis of asthma COPD overlap. Major criteria. This patient should have persistent airflow limitation. Patient's age should be more than 40 years and he should have persistent airflow limitation. On spirometry, FEV1 by FVC should be less than 0.7. FEV1 by FVC. So in the form of this ratio should be always low. FEV1 by FVC should be always less than 0.7 in this patient. And this patient should have significant smoking history. At least 10 pack year of smoking. At least 10 pack year of smoking with significant or patient is having significant indoor or outdoor air pollution. Either patient should have smoked for at least 10 years or patient should have significant exposure to indoor or outdoor pollution. And patient's lung should improve with bronchodilators. Documented history of asthma. Documented history of asthma before 40 years of age. So before 40 years of age, he was having asthma and his bronchodilator reversibility should be more than 400 ml. So at that time, old report of asthma documented history or his spirometry previously was showing bronchodilator reversibility positive, more than 400 ml after giving short-acting beta-2 agonist. It means previously there was some reversible airflow limitation. Then coming to minor criteria, previously patient must be having some documented allergy or atopic rhinitis. Patient should be complaining of some rhinitis, sneezing or wheezing with exposure to dust, pollen, etc. And previously patient's bronchodilator reversibility was FEV1 more than 200 ml. After giving bronchodilator, his FEV1 previously has improved more than 200. So old report showing FEV1 improvement more than 200 is minor criteria. Old report showing FEV1 improvement more than 400 ml is major criteria. And his blood eosinophils are more than 300 per mmQ. So these are the major criteria, whereas here on this side this is minor criteria. To call it as asthma COPD overlap. At present, patient should have FEV1 by FVC less than 0.7, persistent airflow limitation, and patient should have history of smoking or exposure to pollution and previous history of asthma, documented history. His spirometry report is showing FEV1 more than 400 ml after giving bronchodilator. Or minor criteria. Minor criteria in the sense previously patient should have documented history of allergic rhinitis or atopic rhinitis. Then his previous bronchodilator reversibility, after giving bronchodilator his FEV1 was previously increasing more than 200 ml and his eosinophils were more than 300 per mmQ. Major criteria: patient's present spirometry, patient's exposure to smoke pollution, and patient's previous asthma history, definite asthma history, and his bronchodilator reversibility more than 400. Whereas minor, documented history of allergy and his previous FEV1 bronchodilator reversibility more than 200 ml and his eosinophil count will be more than 300 ml. And general treatment for asthma COPD overlap is this. We initially start with LABA plus ICS. LABA plus ICS. If not improving, we may need to go for LABA plus ICS plus LAMA. So this is the usual treatment. Initially we start with LABA plus ICS. Then if patient is not improving, LABA plus ICS plus LAMA. So this completes COPD. So today we have discussed COPD definition. What is emphysema, what is chronic bronchitis, pathophysiology, why there is airflow limitation, why there is air trapping, why there is mucus hypersecretion, why there is pulmonary hypertension, why there is respiratory failure, why there are exacerbations. Then we have also understood in COPD two variants, emphysema, chronic bronchitis. Then clinical features, diagnosis, treatment aspects. So we have discussed the treatment aspects. Then we went into gold, A, B, C, D, where to give, what to give. Then exacerbations. Then we came to what are all the drugs that can decrease exacerbations in COPD. And finally, we discuss how to deal with exacerbation and asthma COPD overlap. So this completes COPD, asthma. So good night students. Any doubts you can ask me now. So invasive ventilator settings, it should be low tidal volume mechanical ventilation. It is same as in asthma. Expiration should be increased. Invasive mechanical ventilation, expiration should be expiratory rate should be increased, and respiratory rate 10 to 14 per minute. Low tidal volume mechanical ventilation, and you should PEEP should be adequate. You should not give excess PEEP. Again, PEEP can cause barotrauma. So whenever you are intubating a patient and connecting to a ventilator, first thing in COPD, so make sure the patient's expiratory rate is increased. Don't aggressively ventilate. So make the respiratory rate 10 to 14 and tidal volume 4 to 6 ml per kg body weight and adequate PEEP. So don't try to increase PEEP to 10 centimeter, 15 centimeter. So adequate PEEP to avoid barotrauma. So these are the four things that you should keep into your mind. So make sure you are making the inspiratory to expiration ratio 1:3. So no need to aggressively ventilate. So his respiratory rate 10 to 14 per minute. And the important thing, tidal volume, you should maintain 4 to 6 ml per kg body weight. And next thing, adequate PEEP. And don't worry about hypercapnia. Mild hypercapnia can be permitted in COPD. It is also called as permissive hypercapnia. No need to bring down CO2 very early to normal value, because already a patient with COPD is adjusted to some amount of hypercapnia. So no need to bring down it immediately. So you can follow this. You can permit some hypercapnia to happen. This is also called as permissive hypercapnia.